Everyone, and thank you for joining today's ICTR Enrichment Series presentation. Before we begin, I would like to start off by reminding everyone that this event is recorded. Recordings of all Enrichment Series events are posted on the ICTR website. You can see the QR code in the upper right of the PowerPoint here. That will take you to our website with a couple links where you can access those recordings. We will reserve the last 10 to 15 minutes or so of this presentation for questions. We do ask that you add your questions in the Q&A feature of Zoom instead of the chat. This way we can track them more readily and they don't get lost in the chat feature. And then as you leave the web invite, we invite you to take a few moments today to complete a survey to let us know what we can do to improve our presentations and what additional topics you're interested in. That QR code is on the bottom right of your PowerPoint. The other thing I want to point out before we get started is that we have this brand new core on the ICTR website. And I want to share this with you because we brought this core into existence because we know that when you're planning your research project, that dissemination and implementation is something that really needs to be considered at the very beginning of when you're designing your project. So if you go to the ICTR website, you'll find this banner here, and when you click on that, this will actually take you to the page about dissemination and implementation and how you can actually apply for resources there. Our guest speaker for this ICTR Enrichment Seminar Series is Dr. Fadia Shaya. Dr. Shaya is also our director of our Dissemination and Implementation Core, and we've taken several months and actually probably 2 or 3 years at really trying to develop this core because of the significance that it is to researchers when they are designing their projects and when they're considering about how to actually get their research out into the community. Dr. Shaya is with the School of Pharmacy. She's a professor and executive director of Behavioral Health Research Team, Data Implementation Science. And she's also the director of the Center on Drugs and Public Policy at the University School of Pharmacy. And she's our director of the ICTR Dissemination and Implementation Core, as well as a co-director for the ICTR Informatics Core. Her topic today is Research and Impact, Dissemination and Implementation Science to Inform Clinical Care and Prevention Strategies from Data to Action. And with that, I'm going to turn this over to Dr. Shaya so that she can get started with this presentation and so that we can have some time at the end for your questions.
Thank you very much, Wanda. I will ask Nicole, please, to share her screen with the presentation. Before and as we look for that presentation to be loaded, I would like to introduce my co-speakers, Nicole Silfon, who is sharing her screen. Nicole is Associate Director of the Behavioral Health Research Resources and Technical Assistance Program, and Dr. Michelle Taylor, who's also Associate Director of the BHRT program. We selected this title, Research with Impact, because of the importance of that translation of research into action. We found that a lot of our resources, human and financial resources, are spent on producing very important and critical research. Where we might be falling into a gap is in that translation of the research into practice, although it is evidence-based practice, but it is that translation that is lacking. And there is a whole science behind it that we would like to talk about today. Here we are, I want to be sure, I also mentioned that we reside in the Department of Practice, Science, and Health Outcomes Research, and many of our colleagues in that department are really involved in their day-to-day job in that dissemination and implementation of research. Next, please. Within that department, we have formed that program to focus on very specific needs that were expressed at the state level. And these we started looking at substance use prevention and also the proper use of prescription drugs. We work hand in hand with all of our jurisdictions in the state, and we make sure that we conduct evaluation and we give those results back to the jurisdictions. Next, please. I would like here to introduce our core team. You have met here on the screen, and they will be talking also, Nicole Silfon and Dr. Taylor. We also have on the core team, Vanessa Michel and Rana Karslioglu, who are public health specialists and program specialists. We have also Paris Barnes, who is our key communication program specialist, and Zelalem Abate, who is a public health research specialist. As part of our core team, we are the team that really works hand in hand with all public health jurisdictions and all stakeholders in the state of Maryland, from the Eastern Shore to Prince George's County to Western Maryland to Baltimore City, of course, with prescribers, public health jurisdictions, health systems, and others to make sure that evidence-based practice is disseminated in a way that is consistent with the culture of those stakeholders. I also want to mention that we have many students, postdoctoral fellows, and other faculty working with us. And I invite you also to inquire about collaborations under the ICTR and also in any prevention program that you might be interested in. So let's move now to the core of this presentation. I want to highlight here that it takes 17 years for your research findings to make it into practice, and that only 14% of your original research is used to the benefit of patient care. That is astounding. When you think about all the waste, this in any other industry will not be acceptable. This is a very, very low yield. And yet we have stellar research that is fueled and funded and operated and published possibly, but not disseminated properly. So our responsibility is the ethical conduct of research. It is to disseminate our findings and distribute our new knowledge. When research is designed to improve health, dissemination of findings can be related to 4 ethical principles. So it's not only about the science, it's also the ethics of research. It is the responsible use of public dollars, the benefits to patients and the public, contributions to evidence-based knowledge and practice to maximize benefit and avert harm, and finally, absolutely the reduction of health disparities. So it is imperative upon us to engage into dissemination. In the next 40 minutes or so, we will show you, instead of telling you, we will show you by way of cases, 2 examples of dissemination that Nicole Silfon and Dr. Taylor will present. I will then follow up with 3 cases informing implementation, and they come from different fields. And then we present a more traditional way to measure the impact of your own research. Finally, we will end with a note on how to actually request the DNI consultation through the ICTR. And before I hand it over to my colleagues here, I do want to thank Dr. Davis and the ICTR for their vision in being willing to create that dissemination and implementation core. Quickly, this is imperative in your grants. So more and more of your grants to NIH and other federal and other agencies are now requiring a dissemination and implementation section on how your evidence-based practices, intervention, and policies will effectively be translated to and used in real-world settings. So it is no longer optional. You have grants that are purely DNI and others that might be clinical or other that would require that section on dissemination and implementation. And this is the formal since we're starting its presentation, I want to be sure you have those formal definitions. That dissemination is about the how, when, by whom, and under what conditions your evidence will be spreading throughout different stakeholders, your agencies, the frontline workers, consumers of public health, clinical services, etc. Implementation seeks to understand the behavior of your stakeholders and support staff, your organizations, consumers, family members, to see how best to be implementing your findings into that culture or that setting. And finally, I would like to show you here what it might look like. So as you develop your hypothesis, this will be one way, not the only way, but one way that you would start to visualize the extent and the impact of the variable that you're looking at, the problem or the component that you're looking at. On the left, we have visualized the distribution of the population of the state of Maryland based on their status of being foreign-born, or so that's this slide. Next, this is on the left. You will see how the data is mapped based on being foreign-born or not in the state of Maryland. On the right, you see that variable or the distribution of the variable of COVID mortality. And here you will note in developing your hypothesis that there are some areas of overlap between the percent of the population that is foreign-born in the state of Maryland and COVID mortality. This simple illustration may lead you to focusing on these areas and investigating some of the underlying causes or some of the contributing factors. You may apply this, of course, to the prevalence and the epidemiology of diabetes so that you can inform your treatment programs and your prevention programs or any other area that you might be interested in. Next. So in summary, you really want to start with the end in mind. You really want, with DNI, to almost write your paper before you start your research. As you embark on research, be intentional about your plan. Track your progress and demonstrate your progress. So first question, who is the main audience? Who stands to benefit from your findings? It's very different if you have in mind your patient population versus your physician population or your healthcare system. Although everyone is in it for improving healthcare, the drivers of the practice of physicians may be very different from the drivers of the practice of a payer, like Blue Cross Blue Shield or the healthcare system. They will merge at some point, but when you are pointing your results to one of these stakeholders, you want to be very specific so that you are relevant to their field of practice. So you want to involve them early on. As you develop your hypothesis, you sit down with your stakeholders and you make sure you listen so that at the end, when you develop your model, you are including the relevant variables in your model. And then also you will know how to start disseminating even before your final results are out. So again, I will end with one very helpful tip is to write the paper before you even start. Start with the scaffolding of your background, methods, results, discussion, and conclusion without even having those results yet, but that will give you that guideline. Examples of implementation outcomes, very different from clinical outcomes, would be acceptability, adoption, feasibility, the fidelity, how appropriate it is, or even cost. I will go more into these. You will look at what are the most effective techniques to improve the distribution and receipt of evidence. What are the most effective ways to incorporate new discoveries and evidence-based practices into care delivery? So what are the most effective techniques to sometimes stop doing what you're doing, de-implement some techniques that might be obsolete or that might be no longer relevant? We always think about implementing and doing, but sometimes you have to de-implement and substitute your process for another one that's more relevant to a changing population. Typical, for example, is the changing demographics in counties. in the state of Maryland, and we will change our interventions based on those changing demographics, based on the practice style of the physicians relying mostly on EHR and no longer the paper medical record. That might change the way that we approach our research and our results. So keep this in mind as you move forward. And now enough about the theory. We want to delve into all the examples. So next, please. I'm going to ask now Dr. Taylor and Michelle to be, Dr. Taylor and Nicole to be giving you some examples from the field of what we've been doing. And I will follow up with 3 other case studies.
Thank you, Dr. Shaya.
Dr. Taylor?
Yes, thank you. So let's take a look at a few dissemination examples. We're going to start out with the first one, which is the hospital events dashboard. So we were contracted by the Maryland Department of Health and conducted an evaluation of the CRISP drug-related indicators dashboard under the SPIFRX grant program. So during the fall of 2018 and the spring of 2019, we evaluated the CRISP drug-related indicators dashboard using a mixed method evaluation. Users reported during that evaluation experiencing problems when using the dashboard. They reported confidence, not having confidence in selecting the correct measures, not being able to find the correct measures and data, difficulty logging in, trouble interpreting data and navigating features. They were frequently reporting these kind of problems. So the evaluation of the dashboard users, we found and recommended that we develop these webinars and tools to assist with the utilization of the dashboards. The evaluation's findings really highlighted an opportunity for additional trainings, including overviews of available data, how to use the dashboards, and examples of how to find and interpret key measures. Based on that feedback from the evaluation participants, pre-recorded webinars were done and they were hosted on the CRISP platform. And the first webinars that were created on the dashboards were 2 webinars specific to the dashboards, and they were on the PDMP and the hospital events dashboard. So first we highlighted how to specifically calculate rates on the PDMP dashboard, and then we also created a 1-pager to accompany it that and then also how to gain access. We did an overview that was also included, and then a hospital events dashboard that also had a 1-pager with that. Since the dashboards were created, as well as the webinars, we've been tracking the users and the views, and there have been approximately 133 views as well as 53 users within those dashboards since 2020 and 2021, and then 57 views since July 2021 to 2022, with 54 users and 100 views so far this year. Jurisdictions also have those 1-pagers as guidance. They're attached right next to the links for the webinars on the dashboard. So when they go in, they can go in to click those guidance documents for reference. They can print them out, and it allows them to pull the key data with the programs and actions that they can use to go along with strategies in their communities. Next slide. So here you can just see the actual 1-pager that was created to go along with the webinar. This is what the 1-pager looked like, and this was catered to what the client asked for. It had their logo as well as our information on it, but specifically took the user through the steps on once they got in there. It had the same look and feel of the dashboard, but also took them through the steps on what they needed to get through and the action steps within the dashboard. One more example, next slide, sorry. Here we were contracted with the maternal child health at the Maryland Department of Health to help them create a dissemination tool that they needed to convey a new referral process that they would be putting into use. After our initial consult with them and some creativity, a few edits and revisions, we were able to come up with exactly what they needed to feel that they could clearly convey to quickly come across to providers their new referral process. And so that they could have a good workflow that was going between the patients, the hospitals, their physicians, any provider that was in this process. They needed to have this process go quickly and that this communication would go easily. So this is just kind of a few examples of how we work with our partners to identify the need, translate the data, and disseminate the product to help provide the tools that are needed to be implemented. And I'm going to turn it over to Nicole for another implementation example.
Doesn't want to change screens. There it goes. All right. So this slide is an example of work that we've done with the academic detailing program, partnered with the Maryland Department of Health, the Office of Provider Engagement and Regulation. And actually, academic detailing is a great example of implementation of information for translation of research, because it's if you're not aware, in an academic detailing session, it's an opportunity to have one-on-one conversations with medical providers around specific topics. For this academic detailing program, we focus on opioid prescribing and related topics to prevent screening of substance use disorder, naloxone, safe storage, all of those related practices. And it provides an opportunity to go through a needs assessment and share related and relative evidence to providers to help make better clinical decisions, knowing that there is so much evidence out there, and sort of bringing that and all that information to them to help guide them in their practice. So these are two examples of some fact sheets that we've created to better assist the detailers when providing their detailing sessions. So the data snapshot on your left is an example of PDMP data, overdose data, and hospital data that we pulled from the CRIFS data dashboard. And it's a great tool when having those initial conversations with physicians and other clinicians around how the opioid epidemic is impacting their practice, and just to provide them with key data to start conversation, to then lead them to other evidence and try and get them to make behavioral changes and interventions in their practice. The additional fact sheet that we create additional fact sheets sort of based on the needs that come back to us from the local detailers to help with those conversations, as well as ways that can assist them in implementation of best practices. So this is an example of a back of a fact sheet that we developed that was in response to a lack of dispensing of buprenorphine mono products by some pharmacies in Western Maryland. So with this fact sheet, we pulled some local data and provided some tips on sort of how to minimize the risk for patients, and gave them some tools on further guidance. So just are some examples of providing the data that exists to have better implementation in practice. So I'm going to pass it back to Dr. Shaya.
Thank you. I would like to thank, Nicole and Dr. Taylor for presenting our work with the state. That's both with jurisdictions, public health, and clinical work. I also want to acknowledge at this point many of our partners at the state level, the Office of Population Health Improvement, Brooke Holmes and Helene Hornham, who our collaboration with them has been longstanding, and that really illustrates implementation and dissemination research in the field, as well as you heard about the Office of Provider Engagement and Regulation. And we have done many projects, as well as for example, opioid overdose to action programs, and more recently, a scan across the state for the educational needs ahead of the adult use for cannabis that will roll out in July. So there's a lot happening in the field, and I wanted to take a break here and thank our partners at the state level for their support and their collaboration, and then keeping us relevant to the state and the needs of all of our jurisdictions, 24 jurisdictions in the state. So with this, I'm going to pivot now to another 3 cases that I will present to you. They've all been completed, and they pertain to different stakeholders, if you will. So the first one here is the case, an implementation case, seeking drug placement on formulary for Ventavis. So this was at the request of a health plan. We had prepared formulary review for the product at the time, and the question was if the health plan should keep it on their formulary or not. As you know, placing a drug on the formulary gives easier access to patients who are prescribed the drugs because it reduces their copay. That's for the very basic explanation. So this is the approach we took to lead to the recommendation that we had for the plan. And in assessing that implementation, we covered pathophysiology, pharmacokinetics, pharmacodynamics of the products, the product background, the treatment guidelines that were issued, clinical evidence that was published, efficacy and efficacy and safety at that time only, economic value. Then we built a budget impact model, and we ended up with a recommendation for the plan. My colleague, Dr. Catherine Cook, works also in the field. We did this as a project for the Academy of Managed Care Pharmacy, and all of what you see here is the product of our work with our students. So we love to involve our students and trainees in all the research we do, and many of them will go on to continue a research career in any of our schools. So we welcome this as well. So as a snapshot of what we did here, we reviewed some clinical trials, looking at the percent, next please, the one up, yeah. The percent of patients meeting certain criteria, whether it is the primary composite endpoint that was reached, a higher proportion in the patients on our drug of interest, the improvement in the 6-minute walk difference, the improvement in the NYFA functional class, and the clinical deterioration. And we had fewer percentage of patients showing clinical deterioration in the product. Next, please. We would also look at the profile for adverse events, and although syncope was more prevalent in the iloprost group, it was not considered or correlated with clinical deterioration. As a snapshot here, next, please. We built a budget impact model. What you will see here on the right is the breakdown, demographic breakdown of the population. So it's not only by age, but we looked at the breakdown by the clinical profile of that plan population. So this is where you start looking at the implementation, you work with your plan, because looking at that formulary placement for a population that has a different profile, whether clinical or age or other, would be very different in terms of how you weigh it. So you note here that 22% of the population of that plan are older than the age of 65. and 61% are between the ages of 18 and 65, with the majority being in the functional class 3. That might be very different breakdown than if you were looking, say, at the Medicare population. So we took the perspective of a health plan and used a 3-year horizon timeframe. Again, this is very important because the health plan is looking at their budget impact. It will be very different from a societal perspective or even a patient perspective. So this budget impact model was specifically for the health plan. Next, please. After extensive analysis, we have, with the building the budget impact model, we showed that the per patient per month incremental difference of the annual budget difference was minimal. Then we considered the market share of the products, and we derived the incremental difference in the average per member per month and the average total annual spending. And then we ran, here you see on the right, a sensitivity analysis, which is intended to confirm the rigor in our model. The sensitivity analysis will vary the value of some of the key variables in the model along some plausible spectrum. So here, for example, we varied by 10% plus or minus the difference in the compliance rate, compliance to the drug. So as a result, next please, we ended up with a recommendation here to keep the product on the formulary because it has been shown to improve the 6-minute walk difference, the NYHA functional class, and the time to the clinical deterioration. We had evidence of safety and tolerability. We had the potential, it had the potential as adjuvant therapy, and there was a minimal impact on the budget for the health plan. That recommendation may have been very different, possibly, if that incremental cost to the plan had been prohibitive. So, and how we derive that, again, is based on the DNA of the plan, if you will, the demographic breakdown, the risk factor, the risk profile of the population, etc. So this is one example that is very relevant to a health plan and where we have done due diligence with building the model. We always end next, when we present that recommendation to the plan, we always end with our references. Next, please, yeah. Case 2 is another example looking at the potential relation between overdose mortality and access to medical care. We look at it as a possible factor that might help inform certain interventions. The target audience here is healthcare providers, public health professionals, health planners, policymakers, and insurers. This is more of a public health problem, but it also, you will see, have some clinical implications. This study was done in collaboration with our postdoctoral fellow, Dr. Sistani, and my colleague, Dr. Rodriguez de Bittner. And it was in view of the high burden of opioid overdose mortality. At the time of our study, over 130 per day in the US, calling for a need for opioid use disorder prevention and treatment. So we wanted to understand what are the drivers in the field. Next, please. So in studying this, we looked at all the states. We looked at that variable across by county. So this is not patient level. This is an implementation study at the county level. We looked at demographics as well as social vulnerability index as a social determinant of health. And our hypothesis was that there might be a difference in or access to medical care and pharmacy care might impact or possibly have some association with overdose mortality. So we looked at the variables of access to medical care, access to pharmacies in that county, and access to physicians as expressed by physician density by county. Next, please. What we found here, fast forward after the analysis, is at the county level, lower physician density was associated with higher rates of opioid overdose mortality. While we controlled for demographics, we controlled for social vulnerability, and we controlled for pharmacy density. So what does that inform? What does that tell us for implementing the intervention? Possibly, since in the unadjusted model, the higher the pharmacy density had an impact on overdose mortality, we figured here that efforts for prevention and treatment strategies should focus first and foremost on the availability and the density of medical care providers. So as a result here, next please, as a result, we will be better able to inform our jurisdictions and our health planners. So in addition to doing the one-on-one outreach of education to patients on the dangers of overdose and opioid use, we had to adjust our infrastructure in the healthcare system. So the last case here that I would like to present is on utilization and spending trends in Medicare. We focused here on anti-diabetic drugs. So why anti-diabetic drugs? Because of the prevalence of diabetes, the increasing prevalence of diabetes. In spite of the availability of treatment options, diabetes prevalence is increasing, and the prevalence of uncontrolled diabetes keeps increasing, possibly due to the aging of the population, possibly due to earlier and earlier diagnosis, and possibly due by the law of supply and demand, possibly also due to the availability of drugs that are misused or underused. So we used here the perspective of Medicare. So from the framework of Medicare, or the perspective of Medicare that is assuming the cost and the management of that population of diabetic patients, they were interested in seeing how is the spend on drug treatment for diabetes being distributed among their overall budget. So we used the Medicare drug spending dashboard and utilization data set from 2015 to 2019. It is a publicly available data set. It includes all outpatient drugs for more than 9,000 medications and devices, with information on spending and utilization. From this data set, we identified 10 common classes of anti-diabetics using the IBM Micromedics data. We adjusted all spending for inflation to 2019 dollars using a 3% annual discount rate. And the question was, what strategies should Medicare consider as it manages a growing diabetes burden, a growing diabetes population, and possibly a growing complications with that diabetes cohort with micro and microvascular complications. So we focus on the drugs in this study. I would like to acknowledge that Dr. Sistani, Rodriguez de Bittner, and myself were the authors on this study. So what did we find here? We found here that Medicare Part D, that's drug spending on anti-diabetics, is 16% of the Medicare Part D spending on all drugs. This is one of the largest shares of any one drug class for Medicare. There is a 50% increase in spending on diabetes from the standpoint of Medicare. So overall, $124 billion was spent on anti-diabetic medications. That's 16% of all spending of Medicare on drugs. And this spending increased by $11 billion or 56% during that study period. Next, please. Here, you see the trend in spending on single agents versus combination agents. We found that single agent anti-diabetics contributed to the majority of total spending at 95%. However, the growth in spending on combination agents was higher at 71% compared to growth in spending on single agents, which was 55%. Next, please. Not surprisingly, the largest portion goes to insulin. So it remains the larger source of total spending on anti-diabetics at the average of 57% of spending per year. But as you see in the figure, the majority of spending on non-insulin anti-diabetics belong to the newer agents, DPP-4, etc., and the combination with metformin. So other classes of anti-diabetics contributed to less than 3% of the Medicare Part D spending. And a final graph here that I will show you with the results is that we looked at the trends. So not only the cross-sectional, but we looked at the trends and how that's going. And to look at the increase in the utilization of different classes of anti-diabetics through 2019. And while the utilization of older agents like metformin remained relatively constant at 6% growth, the number of prescriptions for the newer agents and the combination agents increased significantly. In fact, the growth in utilization of combination agents was about over 1,000%. So the metformin combinations had utilization growth of 460%, and the utilization growth for SGLT2s was about 200%. Why do I show you all of this? It's because Medicare needed to look at what is happening in the field, looking at the context before they could do any implementation or make any recommendations. So we did use to inform the program, Medicare program, we used real world data to highlight the substantial cost burden on Medicare for diabetes treatment, but also to make it more customizable so that they could understand what the drivers were and they could adopt future policies for how to manage the population in a way that would meet the needs of their populations for diabetes control and the deferral or the elimination of complications. We demonstrated a considerable growth in Medicare Part D spending, which is mainly driven by spending on newer non-insulin anti-diabetic medications. And finally, because of the high cost burden, the results underscore the importance for spending on screening and earlier prevention programs before people even move into the Medicare entitlement programs or the Medicare age or whatever, whenever they qualify for Medicare. So these are, I want to wrap up with these three examples here that we gave you three different examples of what could happen in the field, and then preceded by two showcasing two major works that we have across the state that pertain to public health as well as clinical interventions. Next, I would like to move to you. So this case is focused on you. So we talked about, okay, when the evidence is generated, how do you go out and disseminate it? How do you make sure to implement it, that you understand the where, why, who, what, and you meet with them, you start from the beginning. But what happens? I mean, 17% of that research makes it into practice. And that has to start with the time that it is published. So it is really incumbent upon us before we even think about how to change practice or how to change policy. It is incumbent upon us, almost ethically incumbent upon us, to be engaging in disseminating our own publications. And it is not a self-serving exercise. This is considered that this is for the public good, and this is for the ethical use of your public dollars, okay? So here we have a major partner on campus working with the ICTR, and with us, with all of us, is the HSHSL, our library, who will be working with you hand in hand and working with us in the dissemination and implementation core to measure your impact. So what gets measured gets done. That's our mantra. we dial back to you when you publish. So this service will support you on measuring. In the top half of the graph here, you see the graph for a generic researcher on the number of publications per year. The second graph, which is at the bottom half of that slide, is where you see visually the growth in your citations per year also. And that will give you a maybe a sobering picture of where you stand, or maybe a very encouraging picture of where you stand. But regardless, this is very important for you to be able to participate in that dissemination at the granular level of your research. Next, please. So what does your reach summary look like? Working with the library, you can request your research impact report or your reach summary. For a very generic output, it will look something like that. It will include your H index, meaning how many publications have been cited how many times, your total number of publications over the time frame that you give them, your total citations, your average citation count, your median citation count, and how you are leveraging social media. So it is time now that we turn our attention to where the audience is. And very often, yes, it is in the paper journals, certainly, but it is increasingly, especially for newer generations who are reading perhaps less and less longer articles. You want to meet your audience where they are. And social media is here to stay. So adopting it, embracing it, and working with your partners to be able to disseminate your findings, your research, your data, your partnership through social media has almost become an imperative. So I want to thank here Emily Gorman, who is our liaison for the School of Pharmacy at the library. And I know that every school on campus has their own representative, and you can work with them hand in hand to get your metrics, decide what measures you want to embrace, and then strategically target to your key audience or your stakeholder. So we have, next please. In summary, we have given you a quick overview of the field of dissemination and implementation. We have stayed away from too much theory, and we gave you many different examples. We showed you at the beginning with Nicole and Dr. Taylor, 2 examples of dissemination in the clinical care and the prevention fields, where our partners at the state that I have mentioned, whether it is OPER, OPHI, and other agencies at the state, have been critical. They understand the field better than we do, and they have a direct link to our jurisdictions. So we cannot thank them enough for being our partners through this journey. We followed then with 3 case studies under implementation research, one that informed the placement of a drug on a formulary, one that studied the context of healthcare delivery system for physician and pharmacy density in a county to help reduce drug overdose, and the final one that looked at the drivers of Medicare spending, a growing population of Medicare spending on drugs for diabetes. That's also a growing condition within Medicare. To underscore not only the benefit that is clinical, but also the economic benefit of potential prevention strategies. We ended up with how you start with you, and how even if you're not engaging in DNI, how it is your responsibility, it's all our responsibility as researchers to make sure that we increase that 17%. So we need to move that needle, and we start with communicating and disseminating our results. So with this, this is the next steps with ICTR, with how Wanda at the beginning, Wanda Fink has presented them to you. And I will end here with opening it up to questions. Next, thank you.
Thank you, Dr. Shaya. I just wanted to let everyone know that if you'd like to add to the discussion, you can use the raise hand feature, and we can allow you to speak. Otherwise, if you could use the Q&A feature, that would be wonderful. Dr. Shaya, I really appreciate you adding information about the HSL, our library on the campus. I think it's a very underutilized, wonderful resource. And I did not know that they could provide those kind of metrics for our researchers on campus. So that's very helpful. Thank you. Does anyone have anything to add to the discussion? Okay, I'm going to let. There's a few people that are raising their hands, so I'm going to.
Okay. Okay, so Christine,
think,
yes. You go ahead, Wanda, please, with the roll.
No, I was just letting Christine to go ahead and talk.
Thank you.
Hi, yes, this is Christine Valerian. Thank you, Dr. Shaya. This was really interesting. As a communications professional, of course, I strongly believe in dissemination and implementation. That's kind of my bread and butter. And many presentations, I end up starting with my favorite quote by Anne Rowe, a psychologist and writer: "Nothing in science has any value to society if it is not communicated." So you didn't need to persuade me. I'm all in. But I have a question about the line between dissemination and implementation. Sometimes, especially when I'm writing, you have to have a clear division between implementation and dissemination. And as an example, one of the reports that I'm writing right now on behalf of your group with the Maryland Department of Health involving OUD and pregnancy, the scope of work for that report is to have the report shared broadly with stakeholders and the public. So that type of thing, would you classify it as implementation or dissemination, or is it on the fence? Or what are your thoughts on that?
Yes, thank you. Thank you, Christine, for that answer. And I'm going to also call on Dr. Taylor and Nicole to weigh in, but I will start very briefly with saying that thank you for bringing up that report that we're preparing for the Maternal and Child Health Bureau to assess the gaps in maternal and child health with respect to opioid use. At the beginning, we start with understanding the field, with understanding what is the scope of the problem. And I would say that that is the first step in that implementation. So before there's even implementation, that's really understanding the field and understanding the needs. So that's implementation. Now, when it is disseminated and that information then is shared with other stakeholders, then that becomes more of a dissemination communication exercise. Nicole or Dr. Taylor, did you want to add to this? Okay, so I see Dr. Taylor has unmuted.
Yeah, I thought that was a good explanation.
Yeah, thank you. So a lot
Thank you for bringing that up.
Yeah, thank you. A lot of what we do is really understanding the needs of the stakeholder we are working with, and so that we can then build that into our model or whatever we're exploring. So that area was underexplored, and it was looking at the gaps. I do have a question here in the Q&A about the -4. So this is an odds ratio the results of our median age and the unadjusted model for overdose mortality, -4, it was an odds ratio. So this is not the median age. So with the lower age, as age decreases, the odds of overdose mortality decrease. So that was in the unadjusted model though. In the adjusted model, it became anyway non-significant variable. Age did not matter. As you see in that poster or in that results for the overall overdose mortality, in fact, the only variable that showed in the adjusted model that showed significance was physician density at that county. Median age did not matter anymore. Gender or race was no longer significant. And even pharmacy density in the adjusted model with physician density was no longer a major significant driver, although it was a driver in the unadjusted model. So that's what that -4 is. So it's the odds ratio. It is not the actual value for age. Yeah, so thank you for asking that question, Lynch one. Thank you. I believe we are 2 minutes before 1 o'clock, Wanda. We could possibly, if you wish, maybe invite people to contact us with any questions later on. And we always welcome collaborations, whether it is you just have a question or so. You have the contact to go through the ICTR, you have the QR code, you have the website, you have the email address, you know where we are. So if you don't contact us, we will contact you. So thank you. Thank you.
Yes, I definitely wanted to just highlight what Fadia had said about our resource request in the chat. I've included the link to our website, to the ICTR website, as well as the link to the ICTR resources. And of course, our D&I services are at the very top because we feel that those services should be considered first and foremost. And as Fadia had pointed out, research is not meant to be self-serving. So we're going through this process and hoping that folks will take those steps to help move their research to where it's supposed to be targeted out in the community. Thank you, Dr. Shaya and Dr. Taylor and Nicole for joining and providing this wonderful presentation. If we don't have any other questions, I think that we can, I'm just seeing if there's any other, we have no other questions. So with that, we are going to let everyone go. Enjoy the rest of the afternoon. Thank you, everyone.
Thank you.